Hello, everyone. So today we shall take a quick review on this condition we call Pityriasis Rubra Pilaris, and it is one of the conditions that can look like uh, that is grouped under papillosquamous disorders, where we have the psoriasis, the PLEVA, the PLC. So now we are looking at another condition we call Pityriasis Rubra Pilaris. So this is one of the conditions that we need to take in look at. And in the pictures that you see here, we are seeing, at least you should remember this grater. I think everyone has seen this before in the usage at home, and we should remember these pictures. I'm going to explain why. So in Pityriasis rubra pilaris, it is one of the conditions that we see under psoriasis, and it has been given other names, including lichen rubra pilaris or divergence disease, or lichen rubra acuminatus. So depending on the literature that you're reading, you will find these other synonyms or names that have been given to this condition. So remember, at least divergence disease is also the same as Pityriasis rubra pilaris. So it was first described by Claudius Tarol in about 1835, and then Diverge is the one who came and named it the Pityriasis pilaris, and then later on Besner came and added the word rubra because of the erythema that comes with this condition. So it has a equal distribution affecting both male and female equally, and it can either be acquired or even familial. And in case it is familial, it can be either autosomal dominant or autosomal recessive. So it has both acquired form and then also inherited patterns. So the exact etiology of Pityriasis rubra pilaris is also not known, except for the autosomal dominant or the inherited type, where there's a suspected gene mutation in the CAD14, which is also called the psoriasis form gene number 2. Remember, psoriasis form gene number 1 is the one that is associated with psoriasis. Then number 2 is the one that is associated with Pityriasis rubra pilaris. So for the acquired types, it has been postulated that maybe they are due to deficiencies in vitamin A, proposed but not yet proven. It's also thought to be dysfunction in keratinization, and they think about other physical triggers like infections, trauma, sun exposure, and possibly autoimmune systems also play a role. And there's also a thought that there's maybe abnormal response to antigens, especially in HIV and malignancy, also thought to be triggered by drugs. So you may look at this etiopathogenesis, and you'll find that it is actually similar to the one we see in PLC. It is similar to the one we see in lichen planus. It is similar to the one we see in psoriasis. You'll find that all the triggers that are mentioned on the other side are some of the triggers that are again repeated in this particular condition. As we've said earlier, for the autosomal dominant pattern, there's a mutation in the CAD14 gene. So continuing further, in the clinical picture, that's why I was putting for you the grater or the nutmeg grater, is that because of how the lesions look like. So we see follicular hyperkeratosis on an erythematous background. That is why you have the name rubra in the name. Rubra means red, and red means erythema. So in this case, you'll have a follicular hyperkeratotic papules on an erythematous background with islands of sparing, and it will give a nut grater or nutmeg grater appearance, as you can see in this picture. So that's why in these pictures here, in the first one, we're talking about it appearing to have this, you see these keratotic papules, which is giving you a similar picture, as you can see these spaces in the nutmeg grater. And then, as you can see here, we have islands of sparing. Now, this is normal skin, and now this is the affected skin. You see, this is normal skin, normal skin, normal skin in there, normal skin in there. That is what we call islands of sparing. So even in this picture, as you can see here, this area is too much infiltrated, but you see in between these follicles, if I may magnify for you, you will see that we have actually normal skin in between, normal skin in between, normal skin in between. So you'll see that this condition comes with a dermatous hyperkeratotic papules together on an anerythematous background, but with islands of sparing. Okay, so that is the clinical picture that we see in Pityriasis rubra pilaris. So the erythroderma, it can sometimes come with pruritus, a burning sensation in about 20% of the patient with a varying degree of exfoliation. So if it involves the scalp, it can look like seborrheic dermatitis, those greasy scales. And if it involves the nails, you'll end up having picture of subungual debris or hyperkeratosis, yellowish discoloration with thick nail plaque. And then if it involves the palms and soles, it can give you that orange-red waxy keratoderma. So every time you see keratoderma in a child or in a patient, try to look at the skin. If you have now these hyperkeratotic papules, you may be dealing with the patient having Pityriasis rubra pilaris. So then sometimes you can get a Kaposi varicella eruptions. This is a varicella eruptions, and then you can also get it being photo-triggered or even photo-aggregated in some cases. So proceeding further, this is what we've talked about. This is how it will look like. These are the islands of sparing. If I magnify for you, you'll see that in this case, this is normal skin, and then you have these hyperkeratotic papules, and in between, you'll have this erythema. So this picture shows you the island of sparing. At least you can see that you have normal skin distributed within the lesional skin. That is the picture. Sometimes it can be erythrodermic covering the entire body, just like as you can see in this third picture. So just to emphasize the nutmeg grater, at least you should remember this. I put it there because it will give you a visual of how the papules look like. As you can see here, you see these are keratotic papule, erythema. But when you look at the surrounding skin is actually normal. So if it is very extensive, you can still pick out areas of normal skin. So Pityriasis rubra pilaris is actually categorized further depending on one, the age of the patient, age of onset, and later on it can also be either associated with HIV or sometimes even malignancy. So depending on the age of onset, it can either be adult onset, juvenile onset, or we can have what we call the variable onset, which doesn't depend on the age. So under adult onset, it can further be classified into two, depending on the distribution. It can either be generalized, right, or localized, but at the adult type, most of the times it is generalized. And if it generalized, now we can classify it into further, whether it is the classical type or the atypical type. So the classical type or the atypical adult type usually gives the picture that we've been describing. So someone has it's spreading caudally, starting from up going down. We have the red-orange plaques with islands of sparing, then perifollicular keratotic papules, and then the waxy plantar keratoderma. So that is the typical. So under typical, you have the features that we've mentioned earlier. So one, you would have the waxy palmoplantar keratoderma. Then you'll have the keratotic perifollicular papules. Then you'll have that thing of island of sparing. So that is the classical presentation. So usually, if it is adult onset and then someone has all those features, we say this is classical or type 1 Pityriasis rubra pilaris. And why do we need to classify them? Because even the course of the disease varies. So for the typical one, it will remain, a majority of the cases will appear within 3 years without even remission, without anything. And this is usually the common type, and it contributes up to 55% of all patients of PRP. Then, still under adults, you can have the atypical type. So the atypical type will not have all the features that you've talked about, but will just have a few. So in this case, someone will have areas of erythematous dermatitis or eczematous dermatitis. They can get ichthyosiform scales on the legs. They can also get some keratoderma with coarse laminated scale, or they can also get occasional alopecia. So in this case, you will not be the typical site that you see the other side, but you will see some areas of, as you see some keratoderma, you see some each cell form scale, then you'll see areas of eczematous dermatitis, and in this case, they can also get what? Alopecia. So now that is the atypical adult type. We call it atypical because it does not look like the common form, or what you could call vulgaris form. And in this case, it is usually more chronic than the typical form or the classical type. So the beauty it is that it only contributes about 5% of the cases, so it is a little bit more rare. And because of that, it is actually more hard to diagnose. So you have to tie up all these features. If you see alopecia, you are seeing keratoderma, you are seeing form scale on the limbs, you are seeing areas of eczema. So you tie up all this, then you start, maybe the patient has Pityriasis Rubra Pilaris, the atypical adult type or type 2. Then when you go to the juvenile type, the juvenile is one that is divided into two other types. It can either be focal or generalized. So in case it is focal, you'll find someone having lesions maybe on the elbows and the knees with erythema, then follicular papules, and then also prepubertal onset. Usually it comes before puberty, below maybe 11, below 11 or 10 years, the patient has this onset. And usually you remember the location, elbows and knees, and then someone will have there erythema, and then follicular papules. And then remember, this may be also confused because of this distribution. It can be confused with the dermatitis herpetiformis because it also loves those areas. So you have to be very careful when you're making this diagnosis, and then you take off a biopsy to confirm your suspicion. So the focal type in juvenile onset, it's a little bit has a variable course. It can sometimes clear within 3 years or spend a little bit more longer. So it is even hard to predict. But in that case, it is also a little bit more common. It is the second commonest type and contributes about 25% of the cases. Then when you go to the juvenile onset but generalized type morphologically, so this is now further classified into two: the typical type or the classic juvenile PRP, that is similar to the one we've seen in adult, and or we can call it the atypical juvenile type, which is also similar to what we've seen in adults, but in this case it's occurring in children. So the classical type under generalized will have classic features as we've seen here in the adult, and it will usually peak around the first 2 years of life and also in adolescents. So majorly it will also take about 3 years and it will clear, just like the adult typical type, and this contributes about 10% of the total cases of PRP. So when you go to the generalized, but in this time atypical, so still the patient will have follicular hyperkeratosis, they'll have erythema, then they'll get scleroderma-like changes of the hands and feet, and this accounts for the majority of cases that are familial, and usually the onset is within the first few years of life. So remember, we said that in PRP you have cases that are either acquired or inherited. So under inherited, they can either be autosomal dominant or autosomal recessive. And the autosomal dominant type is the one that has been associated with the CAT14 gene mutations. And that's the one that usually presents as the atypical juvenile PRP, or the one we call type 5 PRP. It is rare, contributing on about 5% of the cases, but when you see it, you have to also still tie in the findings that you see. You see now follicular hyperkeratosis, you see erythema, then you see like someone has thickening of the skin, especially here on the dorsum and of the hand, and also on the feet. Then they have and then they have this acute onset, which is usually early in the life, like 1-year-old, 2-year-olds presenting this particular type of skin eruptions. Then you may need to think about the juvenile type, which is atypical. And in this case, it has also a very chronic cause. So it stays there for longer periods of time, more than 3 years. Chronic recurrence cause has been what? Reported. Then we go to the last one, which is variable. And in this case, most of the times it is also generalized. So this one has an overlap with the type 1, and it is the only difference here is that it is associated with HIV infection. So if you're suspecting PRP, adult onset or juvenile onset in a patient that is living with HIV, then this is the type that you can think about. It's a little bit rare, contributing to only 1% of the cases of PRP, and still in the clinical features, on top of what we see in the classical, or in top of what we see in the typical, that is type 1, you'll add on other features, including follicular spines. You can add on acne conglobata, and then also hidradenitis suppurativa. So when you're making this diagnosis, if you see maybe a patient has hidradenitis suppurativa, usually that one gives a little bit of boil-like or abscesses in the axilla, in the groin, in inframammary areas. So you need to now tell, are they HIV positive? If they're HIV positive, then that tick comes. Now, if they're HIV positive, they have hidradenitis suppurativa, then they have palmoplantar keratoderma. Then you're like, can it be PRP? So now you look for other features to try and tie in the diagnosis. Then its cause is still variable, and as we've seen, it is the rarest type. So remember, when you're classifying PRP, based on the onset, it can either be adulthood or juvenile or variable, the one which is not determined by age. So when you go to adult, it is generalized all the time. Adults get generalized type, but under generalized can either have typical features or it can have atypical features. Then under juvenile, it can either be focal, which involves only the elbows and the knees and maybe some areas of keratoderma, or it can also be generalized. So still under generalized can either be having typical features or atypical features. So that is the classification. And every time you're confused, you can refer back to this table, and then you remind yourself of how this PRP is classified. So continuing further, when you take off a sample for histology, PRP will give you psoriasiform dermatitis. That's why it is categorized together with psoriasis. So on top of that, it will give you alternating vertical and horizontal orthokeratosis and parakeratosis, which usually gives what we call a checkerboard pattern. So in this case, you also see follicular parakeratosis in the shoulders of follicular plaque. So you can also get follicular plugging, as you can see in this picture here of histology. So this is what we call follicular plugging. As you can see here, we see parakeratosis involving the follicle. Then the checkerboard pattern is what we see here. For example, now in this case, you are seeing vertical parakeratosis, but then sometimes you see horizontal. Like for example, let me look for one here. So you see, like it's a nice way of explaining this one. So for example, here, hope you are seeing where my hand is. Now you see here in this line, generally there's a depression, elevation, depression, elevation, depression, elevation. So in this case, you are having vertical, horizontal, vertical, horizontal, just like that. Now this is horizontal. Now this time, this side, vertical. So they keep alternating vertical versus horizontal orthokeratosis, and that's what gives a checkerboard pattern. Then you'll have and then you'll have also lymphocytic infiltrate, as you can see here, down here below. These are lymphocytes that are infiltrating all down here. All these are lymphocytes. So at least you remember the checkerboard pattern. Then you remember lymphocytic infiltrate, acanthosis, and then also follicular, or what we call follicular plugging with the parakeratosis. So how do we treat Pityriasis Rubra Pilaris? This is another picture of how it will look like. Now this is what we call follicular plugging. You see this? Then you see parakeratosis. Parakeratosis, remember, it simply means retained nuclei. So you see here. Then for orthokeratosis, you have a thick stratum corneum, which is beyond what you see the normal basket weave pattern. So in this case, you see here, vertical, horizontal, vertical, horizontal, vertical, even the same here. This is horizontal, then this one is vertical. So it keeps alternating like that. So how do you treat Pityriasis rubra pilaris? So in the terms of treatment, we usually use hypotent corticosteroids. We can use STAR, we can use vitamin D analogs like spotrain. Some people think you can give vitamin A, vitamin B supplementation, and vitamin D, as well as acitretin. So all these are treatment modalities that are available, and you can try one by one. So in case everything fails, this is one of the conditions that you cannot treat with phototherapy, because we've seen some cases that have been reported to be photo-aggravated, others photo-triggered. So as you're treating, think about a steroid, think about immune modulator like acitretin, which is a retinoid, and then you can also think about other things like Holter or vitamin D analogs like spotrain. You can also think about tacrolimus, pimecrolimus, all those other immune modulators can give some benefit. So thank you very much. So remember Pityriasis rubra pilaris as we are concluding. Remember the type, the classification, depending on adult onset, acute onset, or variable. So whichever onset, you can either look whether is it generalized or is it focal. So if it's generalized, is it the typical or is it the atypical type? And that will give you the 6 different spectrum or variants of Pityriasis rubra pilaris. Subscribe, share with your friends so that this information reaches everyone. Thank you very much. God bless.